Well, hello again, everybody. In the interest of time, I think we'll get going with our program, but please continue to enjoy your lunch. My name is Tim Sink. I'm president of the Greater Concord Chamber of Commerce. Delighted to have you all here with us today. We will be discussing some critical issues today. What I would like to do to start is to recognize and thank our sponsor, Dartmouth-Hitchcock. We're very grateful for their generosity, for their participation in this event, and for their overall support of the Greater Concord community. So thank you so much, Dartmouth-Hitchcock. Oh, they have a table over here with some information on it, so I would encourage you to take a look at that as the program wraps up. We have two city councilors with us today, Linda Kennison and Byron Champlin, so we appreciate your participation and support. Thank you for being here. And I just wanted to mention a few upcoming forums that you may be interested in. On January 9th, we will host Jeffrey Stewart from the Federal Reserve Bank of Boston. He will present the economic outlook for 2020. He's a terrific economist, so mark your calendars for January 9th. And I think there's information on your tables about that. And then on January 30th, we will be hosting a legislative outlook. Invitations will be going out shortly, but we have a panel of some very well-informed people that will talk about what we can expect in this legislative session. So for this afternoon's program, we've got 5 panelists. And the way this will work is I will introduce each panelist one at a time. They will come up, give an overview, take a seat at the table, and then after that, we'll have some time for Q&A, and would welcome some Q&A from the floor. So we'll start with Chief Bradley Osgood. Chief Osgood has served with the Concord Police Department for over 30 years, and he's held a variety of different positions throughout his career. He earned his Bachelor of Arts degree in psychology from the University of New Hampshire, a Master's of Business Administration degree from Riviera University, and he is a graduate of the 235th session of the FBI National Academy in Quantico. Chief Osgood is adjunct professor at NHTI. He serves on the board of directors for Riverbend Community Mental Health, citizen advisory board member for the New Hampshire Correctional Facility for Women, an advisory board member with the Salvation Army, and a member of the Prescription Drug Monitoring Advisory Council. I think we have a battery issue, so might need a little help up here. Advisory board participant for the State Suicide Prevention Council and committee member for the New Hampshire Law Enforcement Officers Memorial Association. There we go. Thank you. So please join me in welcoming Chief Osgood.
Thank you, Tim. Thank you, the Chamber, for inviting me to speak today, and thank you to the other panelists that have chosen to come. I just wanted to make one quick announcement. Liberty, the Police Department Comfort Dog, will be out in the lobby today about 1 o'clock. If you haven't met her yet, she'll be here today. I will actually stay here after, so if you have any questions for me, I'll stick around for a while. I also have some trading cards, Liberty trading cards, that if you just ask me, and I have a pocket full of those. I do have a limited amount of time to speak, so I'll try to be as brief as possible. As a matter of fact, I'm going to put my stopwatch on. Hold on. I don't actually have a speech or a PowerPoint, but I wanted to start off by telling you a story. And it's the story of my first day as a police officer in the city of Concord. I graduated from the police academy on June 2nd, 1989, and I was 23 years old. When I graduated, they told me to report to duty on Sunday, June 4th at 4 o'clock in the afternoon. I came to the police department in uniform, went to roll call, and after roll call, I was in the watch commander's office with my sergeant, Mike Russell, and my lieutenant, Don Callahan. And they told me that somebody had just walked into the lobby, and they said, "Can you go out to the lobby and help this person? We'll try to find out what's going on." And I said to myself, this is great. This is my first call for service. I get to help somebody. That's why I signed up to be a police officer. I'm going to go and help somebody. So I walked out into the reception area of the police department, and I noticed a gentleman. He's probably in his mid-60s, and he's not wearing a shirt, but he's wearing an Uncle Sam hat. This is June 4th. You know, it's not that suspicious because in a month we're going to celebrate Independence Day, and it's a warm day, so him not wearing a shirt is also not suspicious. But as I got closer to the window and began a conversation with him, I noticed that not only was he not wearing a shirt, he was not wearing pants either. But he was able to be creative, and he actually had duct taped a coffee can around his waist so that he wasn't exposed. And the reason I bring that story up is because that was my first introduction as a police officer to somebody that was experiencing some degree of mental health issues, okay? And so we finally, some of the other patrol officers came in and dealt with that situation. And I remember getting in the police car with the sergeant, and we headed down a main street. Now, I'm not from Concord, so I don't know where we're going. But I do remember we stopped on the side of the road on South Main Street in front of St. John's Church. And the sergeant said, let's get out of the car. I want to go introduce you to a couple of people. We walked down the sidewalk, and I ran into a couple of very unkept individuals by the name of Randy and Beth. And they were homeless. And the sergeant introduced me to them. I shook their hands. We conversed for a few minutes, got back in the car. The sergeant said, those are 2 homeless people. There's 3 homeless people in the city of Concord. There's 2 of them. You need to know where they are and check on them, especially in the cold weather. We got back in the car. We drove down Astoria Street to the legislative office parking garage. And he said, a 3rd homeless person in the city of Concord, his name is Norman. Norman sleeps in this alcove underneath the garage. He's not here right now, but we'll check on him again. I'll introduce you to him. Before the shift ended that night at midnight, we went back. Norman was where the sergeant told me he would be, sleeping in a blanket. 3 homeless people in the city of Concord, 1989, that we're aware of. A little bit later on, so I was now introduced to the homeless issue in the city of Concord. Today, there's probably roughly 350 people that are homeless in the city of Concord in my research. A little bit later on in the evening, we were driving. I remember it was my first day of work, so I remember all this stuff. As a matter of fact, I asked Mike Russell a couple of weeks ago if he remembered my first day of work, and he said, no, I don't. But anyway, we were driving down South State Street near West Street, and I noticed we both had noticed an individual walking down the sidewalk, staggering. It had a very unique gait, something that I recognized to be under the influence of alcohol. I'm a recent college graduate at that time, so I understand what that stagger looks like. So we stop and we identify him, and we talk to him, and in fact, he is extremely intoxicated. We end up taking him to the police department as under protective custody. It's our job is to protect them from doing harm to themselves. And in the process of emptying his pockets, we find that he has LSD on him. And so I'm introduced to substance use and illegal drug use as well. All in one night, I'm introduced to these three social issues that we have here in the city of Concord. There are 3 goals of the police department: homelessness, mental health, and substance use. About 5 years ago, law enforcement across the state, during this opioid epidemic, we announced or proclaimed that we cannot arrest our way out of it. And what we really were saying, it was almost a cry for help. We needed help from our external stakeholders. You know, Riverbend, the fire department, the hospitals, the Homeless Coalition, and others along the way. The only way to solve any of these issues really is collaboration, cooperation, and creativity. Over the past 5 years or so, since this opioid epidemic has started, we've lost, just here in the city of Concord, over 75 people. I have always been talking as the chief for the past 6 years about these calls and what our first responders are dealing with on a day in and day out basis. And I was just talking to Peter the other day. I've never been to one of these calls. I read the reports and I hear the chatter in the locker room. But here I am talking about overdoses and stuff of that nature. But the day before Thanksgiving, and I'm going to actually be quiet here in just a second, but the day before Thanksgiving, I'm at the intersection of Loudon Road and North Main Street at the red light going back to the police station. And there's a call at TD Bank that there's a person that's passed out in their car in the drive-thru. So what do? I just decided I'd stop over there. And in fact, that the person actually was suffering from a fentanyl overdose in this car, in the drive-thru. And this is happening on the streets of Concord, in the streets of New Hampshire. We are doing very, very good work as first responders, public safety, as our mental health and behavioral health, the Homeless Coalition. We're doing very, very good work. We have a lot more work to do. And we really need the support of the community and all of the stakeholders to get through this. So I'm going to leave it at that so I can have everybody else say their piece as well. Thank you. 7 minutes. 7 minutes.
Thank you, Chief. That really set the table very well. Our next speaker, Peter, you're going to have to move this mic up here when I'm done because otherwise I'm going to be up and down. Peter Evers joined Riverbend Community Mental Health as president and CEO in 2013. He also serves as vice president for behavioral health at Concord Hospital. He brings 30-plus years experience in the mental health and human services field, including leadership positions in emergency, residential, and outpatient services. Peter served as vice president for the program operations at the Home for Little Wanderers in Boston before joining Riverbend. And before that, he was the Southeastern Area District at the Massachusetts Department of Mental Health. He was educated in England and graduated from Sheffield Hallam University with a BA in Economics and Business Studies, and he obtained a master's in social work from the University of Kent. And he is a licensed clinical social worker both here and in Great Britain. So please welcome Peter Evers.
Hi, everybody. Whoa. Sorry about that. First of all, thank you, everybody, for attending today. It's funny, we actually have a little radio show that I'm sure nobody listens to with Chris Ryan, and we were having a discussion with David Mara, who is the drug czar, if you like, yesterday, and we said, the best thing about this is we're actually talking about it. We're having a conversation like adults around what to do with the issue of mental health, of substance use disorder, and of homelessness. These the triumvirate, if you like, and the intersection with the criminal justice system is one of the most important issues of our day, which is a strange thing when you think about it, because we've been attempting to deal with this for many, many years. I'm actually not from Concord. You may think that I have an accent, but actually it's you who have the accent, because we invented the language. But when I was working in London years and years ago, I remember I used to come in through the Blackwall Tunnel into the east end of London, and there was a big poster, billboard poster, as you came out of the tunnel, and it said, "Where do you think the homeless keep their meds?" And it was just such a wonderful observation of how difficult it is to be somebody who is not housed. And on top of that, is struggling with many other social issues and probably mental health issues. And in fact, just to go forward a few years. I worked in Boston for 23 years before I came here, and I worked in emergency services and worked with the Pine Street Inn that people have probably heard about. And we used to go out on what they called the O-van, the outreach van. And the outreach van was doctors, psychiatrists, social workers who went out after midnight looking for people to provide healthcare for them in situ. So we would go into drainage ducts and find people, dress their wounds, that kind of thing. And it was just a remarkable experience for me. But I remember on the first night I went out, I spoke to a guy called Jim O'Connell, who, if anybody knows Boston, would know Jim. They call him Saint Jim. He works for the healthcare for the homeless, and he has done incredible things with providing medical care to homeless people. And I rather innocently said, well, how many of these people do you think, Jim, struggle with substance use disorder and mental health? And he looked at me, and you know when a dog looks at you and tilts its head like that? And he said, all of them, you idiot. And I think that's how we have to think about this. These are a vulnerable population. And if we don't think that the work that we do is wrapped around social justice, then we're missing the point, in my opinion. These folks are like you and I. These are folks who have had a bad hand oftentimes and need help. And they don't need to be judged, and they don't need to be put in a box. They don't need to be described as people that shuffle along the street with tardive dyskinesia or some other side effect from an antipsychotic medication. They need to be human. And I think as we begin to have conversations around not the person who is homeless, but the system that we're building around our vulnerable population that helps those people, then we're on the right track. And I do think, since I came to Concord, I was just actually saying to Marianne before we came up here that I said, oh my God, I'm coming from Massachusetts. There's no resources for people. It's going to be awful. But I got here and I found out that there weren't any resources, really, to be honest. Not that there weren't any resources, but there were a group of people who were willing to come together, whose cultures were incredibly different, who thought differently, but had one idea in mind, and that was, how do we create a system that supports people who are less well off than ourselves? How do we support it from a law enforcement position, from a homelessness position, from a social work position? And when we came together and we started to work, we realized that there were many things that we could do. I think about mobile healthcare, and Erin is in the room here, and the work that we've done to help first responders drop people off at our crisis treatment center instead of taking them to the ED or to have them arrested. Because we know, and I know people probably know this, but in this country, we're 5% of the world's population, but we have 25% of the incarcerated population of the world, the whole world. 80% of those people are incarcerated for something to do with mental health and substance use disorder. And 20% of them are in because of something directly related to their disease. So we're locking people up, we're not treating them. But what we're doing is putting our social workers inside the jails. And we're working at the moment with some federal money to help people while they're inside the walls with these issues, and then provide services to them when they come out. And the recidivism rate for those folks is absolutely amazing. It's just dropping precipitously. So this system comes together in a way where we understand each other. And I think about our relationship with the Concord Coalition for the Homeless, where the shelter is going to be opening in a few days. And the work that Ellen has done has just been remarkable in terms of having nothing and then building a shelter and the community coming together. But what are we doing? We're working with them. We have a path worker who is a homelessness worker who goes every day. We have case managers that go down and have conversations with people about their situation and can we help with those services. And with some money that has come in from the feds, I think, I don't know if we've actually closed the deal on this, but we'll be renting a couple of those beds every night so that those folks who come in through the doorway, which is another access point for people with substance use disorder, will be able to get shelter and those reserved beds up to a certain time. All of that speaks to a system of care way of looking at things. It says, where are the people that we need to serve? They don't need to just come to us. We can come to them and we can provide those services. So I'm very proud that I've been a little bit involved with the city here, who has just really committed to creating a network of services that helps those people who are less well off than ourselves. So thank you very much. I know there's many other panelists to speak.
Thank you, Peter. And I just want to say that you have accomplished a great deal in your tenure here in Concord. We know you're moving on, and you will be sorely missed in this community. So thank you. Our next speaker is Ellen Groh. And Ellen has served as Executive Director of the Concord Coalition to End Homelessness since February of 2014. She has a long history of working on poverty issues, and she has formerly worked as a legal services attorney in North Carolina and in affordable housing development with the North Carolina Housing Finance Agency, as well as working with private developers of affordable housing. She holds a Juris Doctorate from the University of North Carolina School of Law and a Master's of Public Health from Harvard School of Public Health. So please join me in welcoming Ellen Groh.
Hi, thank you all so much for having me, and thank you all for being here. As Peter said, I think this is such a tremendously engaged community, and I feel really privileged to get to work here. Truly, people care about each other in this community. So I am going to use a couple of PowerPoint slides, and I feel humbled to come after such great speakers who can just talk off the cuff like that so eloquently. So let's see if this will work. Takes a village, right? Okay, so I'm focusing on the homeless issue, and I'm going to try to keep my remarks short. One thing I loved what Peter said about these are systemic causes. These are not, this is not an individual fault or blame. There's systemic reasons that lead people into homelessness. And the one thing that people may not realize is that of anyone who experiences homelessness, the majority of people, it is a one-time experience, a brief one-time experience. Probably 80% of the people who are homeless, they are financially living on the edge, and there's a crisis that pushes them over the edge, like a loss of a job or a medical issue. For a much smaller percent, 20% of all homeless people, it becomes a chronic condition. And that's what Peter was talking about, where there's substance use disorder or mental health, physical disabilities, all kinds of disabilities coming together that makes it a chronic condition and makes it much more challenging for people to get past those barriers and for people to deal with those issues from homelessness. So I'm going to go quickly through how our agency engages with people who are homeless, in case you're not familiar, and then talk about the trends that we're seeing. So we have our resource center that Peter mentioned, daytime drop-in center where people can get connected with services and where other providers come so they can reach out to people, like the caseworkers from Riverbend come, to create a connection and hopefully open the door to receiving services. We have our winter shelter. That is the new building there that this community made possible. So thank you so much for standing shoulder to shoulder with us to make that happen. I was realizing this morning that I should probably have more information on here. The shelter can serve 40 adults. There's 20 bunk beds in that tiny little building there. It is wall-to-wall beds. Last year was the first year in that new building, and we averaged about 33 people a night last year. There was 193 unique individuals who came through that shelter over the course of the winter, and about a third of them only stayed 1 or 2 nights and did not come back. About 10% of the people stayed over 60 days, so they were there or more. So they were there all winter, really. And by comparison, the year before, the shelter was held in St. Peter's Church, a much bigger room, 3 times the size. But the numbers were similar. There was about 184 adults. There were also additional families in the basement of that building, but there was 184 adults. About a third of them stayed 1 or 2 nights. And I don't have this information up there. Sorry, just realized this morning. It'd probably be good to hear. And again, about 10% of them stayed 60 nights or more. So the numbers were similar. I will say that we ask people, where's your zip code of your last permanent address? And that can be a very misleading statistic, because your last permanent address might have been 10 years ago, or it might have been, it could have been, you just don't know. You don't know how long ago it was, and you don't know if you're getting entirely accurate information. But this past year, about, I'm checking my statistics here, about 2 years ago, about 75% of the people who stayed at the St. Peter's shelter had their zip code of last permanent address was Concord. This past year, that went down to about 60%. So there may be more people coming from other towns. We don't really know for sure. Some people are very transient. They're going to move around from place to place. Other people who are homeless here in Concord absolutely feel like this is their home, even though they don't have a home. They feel that this is their community, and they wouldn't go to a shelter somewhere else, even if there was an opening. This is their home. So let's see. And both the Resource Center and the shelter are low barrier facilities. People are welcome there, even if they have active addictions. As long as your behavior is not disruptive or dangerous, we welcome people. We don't allow use of any drugs or alcohol on the premises, but we allow people who are under the influence. The other program that we operate is called Housing First Concord, and this is permanent supportive housing. This is where people can get a voucher that will pay part of their rent, making their rent affordable to them. They can rent an apartment on the open market, any place you or I would rent an apartment, and they get supportive services. They get a caseworker who is sticking with them indefinitely, for as many years as it takes, until they've made the transition and addressed the underlying issues that may be going on as they are ready. Peter's, I love the way he often says, recovery is not linear. There's always setbacks. So this caseworker is there until the person is completely stabilized, however long that takes. And this is what we really feel is the answer. This is how we are going to address this crisis. You cannot deal with these issues of addiction and mental illness from homelessness. It's incredibly unstable. So with that in mind, our next effort that you've probably read about is that we are purchasing this building on Green Street and going to turn it into 4 one-bedroom apartments for people coming from long-term homelessness. And again, they'll get rental assistance and they'll get that ongoing caseworker support to deal with whatever underlying issues are going on. I want to point out that we are one organization and that there is a host of agencies in Concord who are addressing the issues of homelessness. The McKenna House is the year-round shelter for adults. Friends Emergency Shelter can serve 8 families at a time, again, year-round. Family Promise of Greater Concord can serve 3 families on a rotating basis around the faith communities that are involved. And Belknap-Merrimack Community Action Program provides a homeless outreach worker who we work hand in hand with, and they have a slew of other financial assistance programs that can help people who, again, are on the edge, and we want to keep people from dropping off the edge and never get into that spiral of homelessness. And of course, Concord Human Services, which is City Welfare, better known as City Welfare, does a tremendous amount for people in need. And there's lots of agencies that aren't listed up there and faith communities that are involved in serving people who are struggling with homelessness or on the edge of it. So is there an increase? Well, obviously from 1989, when the 3 people who were homeless were known, by name to the police officers, there's been an increase. In more recent years, it is very hard to track. I just want to alert anyone that sees numbers about how many people are homeless. Take it all with a grain of salt, because this is a population that is difficult to pin down. They don't always want to give you information, and it's not always accurate information, and people can move around. So you have to take it all with a grain of salt. There is a point-in-time count done every year in January, and the report on last January's point-in-time count will come out next week from the New Hampshire Coalition to End Homelessness. They always do a really in-depth report, a lot of analysis, but again, the point-in-time can be used to sort of show trends, and funding is often based on it. Federal funding is based on those numbers, but don't rely on that as a real number. I think I've been told that the report that comes out next week is probably going to show a decrease in several populations of homeless people, but I think we know that that's not what we're seeing. So what are we seeing? So at the Resource Center, these were our numbers from 2018. We would see in the year, calendar year 2018, we saw an average of 35 people a day. This year, up through January, our average is 52 people a day. So that is, I think that's a significant increase. It feels like an increase to us, just physically in the room, in the building, feels like more people. Unique people, unique guests coming through, 541 last calendar year, and this year we're up to 640 already. We did see a spike right around the opening of the shelter in the new building, which is right behind the Resource Center. So there's a much closer connection, which is good. That's a good thing. I think some people who may have stayed at the winter shelters in the past never made it to the Resource Center. And now, since it's right across the driveway, they are making it. So that's a good thing. Again, this sort of transient nature and difficult to track people, 35% of the guests who came this past year, they've only come 1 or 2 times and then we don't see them again. So we don't know, did you get housed? Did you just move to another community and you're still struggling with homelessness? Or are you still living here by the river and you're just not coming into the Resource Center? There's no way to know that. And 20% of our guests visit, 3 times a week or more. We know them very well. We're working with them, but there's a lot of things to overcome to move out of homelessness. So what is driving the increase? I will say the number one thing that's driving homelessness in general is the lack of affordable housing. This is a crisis level in this state. Rents are increasing. The vacancy rate in Merrimack County right now is 0.5%. 5% is considered a healthy vacancy rate. We're at 0.5%. So even if you have rental assistance, you cannot find a place to use it. What this means is, so the National Low-Income Housing Coalition does statewide studies, and they found in New Hampshire, for every 100 extremely low-income households that we have, there's only 31 available and affordable units there. So people just cannot find an affordable place to live. And that's doing 2 things. One is it's pushing people closer to that financial cliff where one little emergency is going to topple you off into homelessness. And it is also preventing people from leaving shelters. There's lots of people, especially in our year-round shelters, who have a job. They could get an apartment if they could find one that was affordable, and they can't. And that kind of stops up the works, if you will, for that person who falls into homelessness. There's no space in the shelter because this person who's ready to move out can't find a place to go. And that includes people who have rental assistance. They can't find a place to use it. And of course, the substance use disorder crisis is driving this increase in long-term homelessness that we're seeing and the difficulties of helping people move on. So proven solutions, eviction for homelessness in general, eviction prevention is number 1. If you can stop someone from falling into that spiral in the first place, that's your best bet. And that's the work that the CAP agencies do with short-term assistance to get you through a crisis. The housing first model that I described before, where you have rental assistance and that caseworker support, that's so important. That's been proven nationwide, 80 to 90% effective in keeping people housed. And it overall costs less to the community because once you're housed, you're not going to the ER as much, you're not getting arrested. All of those uses of public services go way down, and it actually costs less to provide permanent supportive housing to people. Addiction services, and I bet this will get talked about later perhaps, but the need to have them available the moment someone is ready. I can't tell you how heartbreaking it is to have someone come into the resource center and say, I'm ready, and we can't find them a place, and they are not ready tomorrow. They're done. It's over. You missed your window. So having that service available while that window is open is essential. And I know the states receive more money for that, and it's hard to get it mobilized. We don't have everything in place to get that going, but that's going to be critical. Two other things I'll add that are not on there. There is momentum in the state around dealing with this issue. I don't know if many people have heard the governor had convened a task force over the summer to address this affordable housing crisis, and they came out with their recommendations, I think it was last month. And the governor will be pursuing those through executive order, and some will be being introduced into the legislature this coming year, but they do have to do with some more incentives to build affordable housing and reduce regulatory barriers to that. And also, New Hampshire Housing Finance Authority is hosting an institute this spring where they're bringing together service providers like ourselves and housing developers and property managers, bringing them together to increase the capacity for us to create more supportive housing for all the populations, including people who are homeless or adults with developmental disabilities, people who need supportive housing, to get that built so that we have places for people to go. So that's all really promising. I think this is a daunting task, but I think there's a lot of promising lights in the future. And I will point out that there are 4 communities in the United States that have effectively ended homelessness in their communities. And that means that all of the chronically homeless people have the supportive housing they need, and they have a system in place so that if someone does fall into homelessness, it is rare, brief, and one time. So it can be done. We can do it. It's going to take all the collaboration that these guys have been talking about in order to make that happen. And I'm going to end with one last thing, and that is that when I first started this job about almost whatever it was, whenever I started, I met with Ken Norton, who's the executive director of NAMI New Hampshire, and he said something gave me some great advice. He said, "Nothing about us without us." And what he meant was that when you're dealing with any issue that affects a certain population, you need to have members of that population at the table, part of the discussion, part of the solution. So it can be a little intimidating to talk to a group this size, and if someone's coming from homelessness and a lot of trauma, that can be extra intimidation and extra challenging to come and tell your story. So I have a little clip of one of our clients. It's just 30 seconds. We have a longer version on our website if people want to hear more, but I really thought it was important to bring the voice of somebody who's going through this to this discussion. So,
from the time I was 15 right up until I was 31 years old, I was a Mason. One day I ended up going off a roof 30 feet. It took me 5.5 years to learn to walk again. I lost my house, I lost my truck, I lost my car, I lost my wife, I lost my kids. Being housed, I found me. That didn't use, that didn't drink, and I'm grateful. Without the Resource Center, I would have been lost. I would have been dead.
Concord Coalition to End Homelessness. Your support matters.
So thank you very much.
Just need that. Thank you, Ellen. Our next panelist is Jeffrey Stewart, and Jeffrey has been in EMS since 1986. His career thus far has included practitioner, educator, and leader in military, private, and hospital-based systems. He's a nationally registered paramedic with state licenses in New Hampshire and Massachusetts. He is also an ARISE certified interventionist level 2. He's the current chair of the New Hampshire EMS Medical Control Board's EMS Drug Diversion Task Force and has been teaching on the subjects of illicit substances and substance use disorder since 1998. He came on board with Concord Fire Department at the end of April 2019 to develop and facilitate Concord Fire Department Mobile Integrated Healthcare's Project First program, which he will explain to us right now. So please welcome Jeffrey.
Well, good afternoon. Thank you very much. Thank you to the Chamber for hosting this event. And just as importantly, if not more so, thank you all for coming to this event. We really appreciate you showing up and attending. I'm going to steal the Chief Osgood's idea and put my timer on as well so I don't get in trouble too much. Although. So Project First It came from a federal legislation, FR-CARA, which is the First Responders Comprehensive Addiction and Recovery Act. And I'll give Congress credit. They created the law. More importantly, they funded it. Then the next point of credit they get, they shifted it over to SAMHSA, which is the Substance Use Mental Health Services Administration, to administer it. So I give them credit. They created it, they funded it, and they handed it off to somebody to manage it. So well done. That's been done. New Hampshire, and so the grant was created, the process was created, and communities could apply to SAMHSA for the grant. The state of New Hampshire decided they were going to apply as a state. Right now, we're the only state in the union that has gotten a state level grant from this funding source. And New Hampshire calls it Project First. And first responders initiating recovery support and treatment. And if anyone has any questions, just hit me up and I'm happy to provide them, no problem. 3 primary goals. We're going to educate the public and first responders about substance use disorder. Now, specifically when the grant was created, it was opioid use disorder, but I kind of pushed back a lot, at least within the greater Concord area, and we're looking at it from a whole substance use disorder. Just quick clarifier, substance use disorder is the umbrella. Opioid use disorder is one of the 9 recognized substances, so I immediately see the heads of all my LADAC and MDAC and substance use disorder clinicians going, yes, good, Jeffrey, check, got that. Pass that quiz. So it's an umbrella term. Opioid use disorder is one of those 9 substances. And so we're educating both first responders and the public about the issue. The second thing we're doing is we're providing opioid overdose kits. Naloxone, Narcan, people know it more as Narcan. Narcan's the brand name, naloxone is the generic name. And I do get pushback from that. Why are you using naloxone in just 2 seconds? We're providing naloxone as a harm reduction technique. All naloxone does is reverse the overdose. It prevents the death. And if you think about it from this perspective, if the patient is dead, there's nothing left to do. There's no more hope. So naloxone, harm reduction, to facilitate and maintain hope. As long as I have that patient awake and responsive, there's an opportunity to get them into treatment. So just keeping that in your mind when we talk about naloxone. Third step, of course, is written a little broadly in the grant, was a collaboration. They wanted the first responder agencies to collaborate with other services within a community to facilitate people into treatment. Concord took that in the next step, and we'll get into that in a second. Now this grant, like I said, the state of New Hampshire got it, and it's specifically maintained through the Department of Safety. There's our opioid overdose kits. So everyone can see what's in them. Naloxone, a pair of gloves, a face shield. Nice bright green kit, easily spotted. So if you see those floating around, they probably came from me. Project First here in the state, we have 7 agencies currently involved. They are doing it in various levels. Some agencies are doing what we call a leave behind. So if the person has an overdose, they leave a naloxone kit at that residence or that location, either with the person themselves directly and or their significant other, their support network, and that's a leave behind concept. Other programs like that, and then they're developing teams to go meet with the patient who may have experienced an overdose and attempt to do some facilitation, barrier identification, and encourage them into a treatment program. And then what Concord's doing, we got tagged as the lead agency, so we're doing the education. We're doing an actual enrollment or an intake process where I will meet with the individual who is overdosed or a referral, we'll talk about that in a second, and I'll enroll them into our program, and then I work with them similar to a case manager, and I really focus in on barrier identification. Where are they? Meeting the patient at their location, both mentally or physically sometimes within the Concord area. So meeting them where they're at. You heard that phrase earlier today. And I'll enroll them. Of course, we get all our confidential things in play and we can share information. We really work on those barriers. Why aren't you in treatment? Do you want to go to treatment? Are you ready for treatment? Are you homeless? Do you not have insurance? Do you have a domestic violence issue? Do you have some kind of charges? What are those barriers? We identify those barriers and we work on reduction of those barriers. And then when they're ready, we facilitate them into treatment. The way we facilitate them into treatment is that collaboration perspective. I work closely with the Doorway and other agencies to get that person, when they're ready, into treatment. Just some data, because people are always asking me about data. So I came on board April 29th. We went live with our program June 24th. Our substance data I started tracking from January through November 30th. So about 66% are men, 33% are women, 1% transgender. Average age for our overdoses is 39.7 years. That's the average age. It's not 22. We transport about 78% of the patients. So that means about 22% don't want to go with the ambulance. They don't want to go into the emergency room. We've distributed about 170 kits so far. And then the other data up there, you see about 46% of our overdoses that we, Concord Fire Department, go on are opioids. 32 alcohol. 8% I have is other, and just so you know, that's polysubstance or benzodiazepines or antidepressants, combinations thereof. That's the other category. 7% stimulants, 4% marijuana, and those are isolated marijuana. That's why we were there. Person in their mind overdosed on marijuana. And then, of course, 2% are unknown, and then 1% cough syrup. And they were really after the dextromethorphan hallucinogenic episodes. So we review all of that. Some other data. We've been doing classes. I've done about 16 first responder classes, 12 community classes, and we've impacted about 130 people. We've been handing out the naloxone kits, as I mentioned earlier, about 170 of them. As you see up there, we offer hands-only CPR and naloxone awareness training on regularly. I haven't posted the 2020 dates, but our next class is December 23rd at 6 p.m. It's open to the public. You just call and register. It takes us about an hour. We do hands-only CPR and naloxone training right then and there, and you walk out with a naloxone kit. And we'll have the new dates up on our website shortly for 2020. I think just to tap on really quick, a couple other things that were mentioned. It is a collaborative event. It's a collaborative episode. You heard the law enforcement and Chief Osgood. We're not going to police our way out of it. We're not going to totally healthcare our way out of it. And we're not only going to social service our way out of it. It's going to have to be a collaborative effort, all hands on deck to support and surround our patients and work them into recovery. So on that note, thank you very much. And I went 1 minute over, sorry.
Thank you, Jeffrey. So finally, wrapping up our panel this morning, or this afternoon, is Dr. Carolyn Kerrigan. Carolyn is active emeritus professor of surgery at the Geisel School of Medicine, active emeritus professor at the Dartmouth Institute, medical director, patient-reported outcomes from Dartmouth-Hitchcock Medical Center. Dr. Kerrigan holds a Master of Healthcare Delivery Science from Dartmouth College, a Bachelor of Science degree from McGill University. She received her MD from McGill University, and also a Master of Science from McGill. And she is also representing our sponsor today. So please welcome Dr. Carolyn Kerrigan.
Well, this is amazing to hear the stories of all of you who are working very much at the front line. What I'd like to do is just introduce you to a relatively new model of education that Dartmouth has begun to deploy. And one of our first initiatives was to try to help employers who are willing to become recovery-friendly workplaces. And I'll tell you a little bit about this educational model and then tell you about our initial experience. So it's known as Project ECHO. And basically Project ECHO began in healthcare, and it was designed by a gastroenterologist, an intestinal expert in New Mexico back in 2003. And he was very much wanting to engage rural community family doctors to initiate early treatment for patients suffering from hepatitis C, who otherwise did not have access to his specialized knowledge. It became a highly successful model that has spread nationally, spread internationally. And what has come of it is that it no longer is just restricted to medical education. Many other sectors, whether it's the public sector, education, law, social works, many other sectors have discovered the power of this learning model. When you see like telementoring and you hear virtual technology, often people say, well, how is that different from just joining a webinar? You know, why is it different? So I'll just show you briefly what the structure of a typical echo is. Imagine you have an hour at lunch and you join one of these sessions. In the first 10 to 12 minutes, you'll get a brief didactic that might be very similar to what you'd see on a webinar, but much shorter. Then comes the real meat. All the participants have been asked to submit cases, and everybody are people like yourself in the room. They're adult learners, and they learn best when they're very engaged and they're discussing things that are very real to them. So by submitting cases, the cases are discussed. There's a round of clarifying questions from all the participants, and then a round of discussion about recommendations, not just from the individuals running the session, the experts, but also the other people who are involved in the call. So that's in a nutshell, sort of how an echo session works. Some of the principles is this is about moving knowledge, not people, particularly when you're dealing with rural communities. And Dr. Aurora, the originator of this, often uses the term, this is about democratizing knowledge. And typically there's no charge for participating in these sessions. These are free to the learners. So we sort of shown you here the structure of an echo is that you do have some subject matter experts. I'll talk a little bit more about that, but they're there to share their knowledge, also to learn from the participants, and they're key to helping facilitate a learning network. The participants is anybody who's signed up for this session, and typically we would like not to have more than about 30 to 40 people on a session at a time. Otherwise it gets too big and it gets in the way of the learning. And they're there to acquire new knowledge, also to share their knowledge, to gain confidence in an area that perhaps they were missing some confidence, and then to join a network of interested individuals, almost a built-in support network who are interested in learning about the same topic. And they in turn, once they've gained that confidence in the new knowledge, can impact a large number of people that they reach. In medicine, we think about the patients reached, but in other areas, it could be about employees reached, or it could be about community members reached. So the subject matter experts who are in what's in echo language is known as the hub are typically in one room on video camera. And I just want to follow up, I think, on what Ellen said. We always make sure that we have a patient family advisor in the hub, somebody who has a lived experience of the condition that's being discussed. And that's really key to keeping a good balance. The participants up here on the video screen, they're all sitting in their home, at their desk at work, in their car, on their smartphone, on their computer. Some who can't do that at the time can still listen in, and I'm looking at Jeff here, who participated in our echo, which I'll tell you a little bit more about, but Jeff was not able to be on video or to speak to us, but he was fully engaged and was typing away on the chat when he had some input to make. So we can be pretty flexible about how people participate, but it's very powerful to see people's face on the video. That's a real plus thing with this model when it's possible. So how does this relate to the discussion today? So Dartmouth undertook to engage a network of employers who were struggling with employees with substance use disorders. And if we think of this ecosystem of homelessness and addiction, and certainly employment is one component of that. So what we did is we had a panel of subject matter experts, some clinical leaders, some employer leaders, some substance use providers, and legal experts. And we had 40 individuals representing 26 different organizations that signed up as participants. Working with the Recovery Friendly Workplace, and I just want to acknowledge Karen Morton-Clark right here, we thought of this as a pilot echo, just to see how it would work, how the community would receive it, and help decide whether we would continue with this model, which I can tell you we're planning to. But the first 4 topics that we undertook, you can see there a lot of discussion around the stigma of substance use, a lot around the employers who want to be recovery friendly and what do they do about policies and practices, a lot of discussion about legal responsibility, and then a session on what are the resources that employers can access to help their employees in need. Because I wanted to emphasize the importance of case presentation, I just want to briefly show you 4 cases and maybe just focus not on the whole description, but on the topic that ended up being the focus of the discussion. How do we reduce stigma? That was a really important thing for this group to cover and led to a very powerful discussion. Another one is, what do you do when you have an employee who is clearly impaired in the workplace? What is your responsibility and how do you react to them? Again, generated a very robust discussion. Do you have insights, tips, or tricks that will ensure you get the truth from an employee regarding their substance use status? This again was a great discussion, tied a lot into stigma, but very insightful. And then one of our final cases was around incorporating recovery-friendly language into planning social gatherings. You have a gathering like this in the evening. Do you serve wine? Do you not serve wine? Do you have an open bar? How do you, as an employer, deal with those issues? So just very briefly, at the end of these 4 sessions, we surveyed our participants, and 84% reported being confident or highly confident in their ability to address this in the workplace, compared to 28% pre-participating in 4 sessions. 100% expressed a decreased sense of professional isolation, which I think is really key. And then 91% are acting with, their feet. They would definitely attend future echoes. So thank you. Oh, and I should have said, if you want to learn more about ECHO, we have a little table set up, which you can drop by on your way out.
We do have a few minutes for some questions, and so I'm happy to entertain a question from the floor. Somebody over here? Councilor Chapter.
Thanks, Ken. This is a very low-level, very general, broad question that probably doesn't speak to your expertise. But it's one that I find myself wondering about frequently, and that is, how do we communicate and educate the general public to the complexity of this issue? Because we continue to see very well-meaning letters to the editor saying, well, why don't you just have the homeless, pick up trash and pay them for that, and that'll take care of the problem. And yet we know that it's about being out of a job, or it's about being in a low-income job and unable to afford a place. We know that from what Ellen said, that there's I was shocked at your statistic. I was saying about 1% vacancy rate. 0.5% vacancy rate is really shocking here in the city. So I guess, how do we generally try to raise public awareness so that we have support for the really broad-ranging initiatives that we really have to utilize? Thank you.
I'll chime in. I'll chime in. My honest opinion is I think venues like this go a long way. And the Chamber's hosting one today in the middle of the afternoon. I think public information sessions where they can go get information on what's the city doing, information from subject matter experts, and having those available, and an area for follow-up. So for example, because I was reminded to give this plug, over on the table over there, there's a lot of information regarding subjects today. So again, a center point for more information. So I think education is key. Panel experts, interactive, that type of stuff.
And also to Councilor as Peter mentioned, he does a weekly radio show. I do those weekly radio shows with Chris Ryan as well, and I know Fire Chief Dan Andrews does. So we use all those platforms to try to really get our messaging out there as well.
Yeah, I would say it's the humanization of the individuals that we're dealing with. I think it was wonderful that you ran that little clip, because that is the face of somebody that's homeless. Also the face of somebody who once was a Mason, who had a family, and he lost that family and became homeless, but then took advantage of what was presented in way of help. And it's just like connecting us as a population to the population of the homeless is really important, because if we just think of them as people who have failed or who don't have family or don't have children, then it's easier for us to sort of not think so deeply about it.
Mr. Dupree.
Ellen, I have a question for you. And Chief, we've talked about this before when I was on the local committee. I'm on the statewide coordinating committee on homelessness, and we estimate there are about, the last count, there were 4,500 chronic homeless in New Hampshire. Chief thinks we have 350. I know you in the past have said of people who sort of linger here, it's more like 100. I would note our population is 3% of the state population. If the 350 number is right, then that means we have about 8% of the state's chronic homeless here, which would seem to be a lot higher number than I've heard you discuss in the past.
And like I said, this is so difficult to track, and people do move from community to community. We are guessing based on the people who come into the resource center and what they tell us. Our caseworkers have pretty close relationships with a lot of people. So we're guessing 150 people, long-term chronic, that's a very technical definition, but chronically homeless people who are struggling with all of this, living down by the river or living in their car. That is our best estimate. I could be wrong. I'm first to admit I could be wrong. I think Manchester is absolutely a focal point of people who are homeless, and Concord and Nashua, and Portsmouth. I mean, all the major cities become the focal points. There's absolutely no services out in Hopkinton, for example. So you have to gravitate to where there are services. Did that answer your question or not?
Yeah, no, I think you're right. The chief thinks it's higher than that.
Well,
I'm just trying to figure out how you guys coordinate on methodology.
So the numbers I get also include people that are couch surfing, people that are on the verge of becoming homeless. This research or this data is coming from outreach workers in the field that are meeting with these folks on a daily and weekly basis. So that's the estimate that I'm getting from those outreach workers. And
I totally agree with that. If you're counting people, I'm talking long-term chronically homeless people with that 100 to 150 number, which takes a lot more resources to help that person, and they also use a lot more resources than the person who is couch surfing and will hopefully not ever need the shelter. They'll have that couch until they can get their own apartment.
Thanks.
Yes, ma'am.
Hi, my name is Rachel Parker. I'm the Assistant Director of Pace Career Academy, a charter school across the line in Pembroke. Peter mentioned the lack of resources in the area, which definitely hits close to home with our student population. Around 87% of our students qualify for free and reduced price lunch, which means that they are considered low income. We have a student support team at this school, which provides a lot of social, emotional support, but we're also working really hard to connect them with resources like Riverbend, NAMI, fast forward teams, and a lot of times they're on wait lists for a long time. And then once they are finally ready to get these services, we find transportation to be a really large barrier. With that low-income community specifically, the young people themselves either can't afford driver's ed, don't have a car, their parents are working 2 to 3 jobs, and that proves to be very difficult for the family, frustrating for us, and I'm sure for the community resources as well. To the panelists, first off, thank you so much for all of the hard work you're doing in our community. It's amazing. But I'm also wondering if you have any thoughts or ideas around transportation and helping this vulnerable, low-income, struggling population in our area. Thank you so much.
I'm not sure where to direct that.
I think, well, yeah, I mean, transportation is a really difficult issue. I would say, though, and this is I'm not avoiding the question, but I do think that we need to transform our healthcare and education system completely so that we're a value-based system. So we're not generating encounters of care. That way, with capitated rates, we get to provide services that people really need, that it might be outside of medical codes, for instance. So you could write a prescription for transportation. That's a great thought, right? That what happens outside of the healthcare or education establishment and the social determinants of health, if you like, those things that negatively affect our ability to learn, live, and love, are the things that in medicine, I believe, should be the next era, which is a value-based level of care that gets people what they need, that might be outside of a Medicaid code or whatever.
I'll just chime in as well. As most of the community knows, the police department engaged in this Operation Blue Elf program, where we had a donor, individual donor, anonymous donor, donate $50,000 to the Concord Police Department last year, and another $50,000 this year. So, for somebody that's in need, if they're a Concord resident and they're in need of assistance with, the driver's ed, if you want to reach out to me, I might be able to use some of that funding and try to carve out a piece of that as well. And maybe I don't know if there are grant opportunities for that type of stuff, but you contact me, we can talk about it.
Dr. Kerrigan, can you talk a little bit about the maturity of the ECHO program and how employers connect and take advantage of that?
So the program that we launched was a pilot program, and there was so much enthusiasm that we are going to continue and plan to launch a second one. We're just trying to sort out how to make it sustainable and find a couple of employers who are willing to help sponsor at least some of the sessions in part. But while I have the mic, I just want to comment on the social needs, because I think what Peter said is absolutely key. And one of my other roles at Dartmouth is to help standardize how we're screening patients for social needs as well as their mental health needs. And we're trying to embed that in all of our primary care clinics so that it's done systematically. And then as we recognize individuals who do have these needs, whether it's a transportation need or a legal need or a housing need, that we will have built a robust enough network that we can help connect resources. So we don't actually have solutions, but we think we can do a better job on the healthcare side of systematically screening for those individuals.
Yes, Brenda.
Rachel, connect with me before you leave. I have a nonprofit, Hearts for Kindness, that might be able to help some of your students. And then I had, for Ellen, the shelter, what are the time periods that it's being used throughout the year, and if it's using it longer?
It is a winter-only shelter. So this year, I know there was some press about this. It's going to open on Monday. And part of the reason we weren't able to open during that storm is that we're just not able to nimbly turn on a dime. Like there's a process to hiring and training, and we were in the middle of that and couldn't just open safely. So in future years, we might be able to stretch that up to the beginning of December. But it is a winter-only shelter, and that is partly dictated by, we squeezed that building into the back of that lot and had to get a lot of zoning variances to do that. And it was based on the fact that it would be winter only. So that is all that is allowed. I think that it would have been much harder to get those variances if we said we're year round, because there really isn't enough space to do what we're doing back there. We're just making do with what we have. So it opens at 6:30 at night, and people have to leave at 7 in the morning. So it's nighttime only, winter only. We tried to time it around when people leave the friendly kitchen typically, that there's not a lot of lag time. You leave the friendly kitchen and you come and you get into the shelter.
I'm assuming you are looking for volunteers.
Yes, please, we are. Look on our website, there's a place to sign up. We're absolutely looking for volunteers. The reason we're able to operate this on the limited budget that we have is that it's supported by volunteers. And there's paid staff who are in charge, but they need the volunteers to keep the place safe and smoothly running.
And that will stay open until about when?
End of March.
Oh,
so
okay,
it's
good. So longer than what we had in the
no. I think it's been that for quite. I'm not sure. Last year it was till the end of March as well. So it's.
Could I jump in and just say that
Get up here.
But temporary housing is not the mission of the Concord Coalition to end homelessness, and that the CCEH really stepped in to meet a pressing community need that was evident after the temporary shelters that lasted for 10 years at 2 of our local churches closed. I always try to give kudos to the CCEH for responding to a community need that really was not their charge, but that is filling a very important role in our community.
Thank you.
Well put, Byron. I think at this point we're going to wrap up today's program. I do want to thank our panelists. This was very information rich. Thank you so much for taking your time and joining us today. I also just want to thank Dartmouth-Hitchcock once again. We can't do these types of programs without the support of organizations like Dartmouth-Hitchcock. So thank you so much for supporting us. And I hope to see you all January 9th at the Economic Outlook.